Welcome. Today I am going to discuss the clinical presentation of allergic rhinitis. The presentation will be done with the help of Katie, standing to my left, who has allergic rhinitis, and has volunteered to help with us with the video.
Thanks. I am excited to be here.
Katie, what symptoms of allergic rhinitis have you experienced?
Well, mostly sneezing, nasal congestion, runny nose, red, itchy eyes, and cough. The mucus is thin and clear. My nose itches sometimes too. It depends on the time of year. My symptoms are worst in the spring and fall.
You just described some common symptoms of allergic rhinitis. Other symptoms could include postnasal drip, irritability, fatigue, nasal obstruction or itching of the palate. Decreased sense of smell and taste is possible. The symptoms should be consistent with physical examination findings. Allergic rhinitis is classified as seasonal if the symptoms occur during a certain time of year like fall or spring, as opposed to perennial rhinitis, where the symptoms are present year-round or at least 2 hours per day for 9 months of the year. 56% of patients have perennial symptoms while 11% have seasonal symptoms only. The rest have perennial symptoms with exacerbations that vary by season. Seasonal allergies or hay fever, such as yours, are associated with tree, grass and weed pollens, whereas perennial allergies are typically due to animal dander, dust mites, or cockroaches. Both types of rhinitis are IgE-mediated reactions. Let's talk about some common symptoms individually in the order of examination. The physical examination should include examination of the skin, eyes, ears, nose, throat, neck, and lungs to look for any associated systemic disorders. First, the skin should be examined for urticaria, commonly known as hives, or signs of eczema.
My doctor says I have eczema on my hands because they are always dry to the point where they sometimes crack and bleed. I have to use special emollient hand lotion. Sometimes I wake up with very itchy, red, raised patches on my arms and face, but it goes away soon after I apply a topical steroid cream from the drugstore.
Yes, topical steroids are effective at alleviating urticaria but should be used sparingly. Let's move on to the eyes. The eye examination should include examination of the conjunctiva, as they are often inflamed or edematous with punctate papules. Ocular examination may also reveal findings of injection and swelling of the palpebral conjunctiva, with excess tear production. The patient may complain of itchy, red eyes and repeat white discharge from the medial canthus.
My eyes do get red and itchy. It seems to occur when my other allergy symptoms worsen. I also have dark circles under my eyes, along with these fine lines under my lower eyelid. I'm only 24. That's too young to have wrinkles.
Infraorbital edema and darkening due to subcutaneous vasodilation are typical of allergic rhinitis, and these are known as allergic shiners. The accentuated lines that I see under your eyes are called Denny-Morgan lines and commonly occur alongside of allergic shiners in the clinical presentation of allergic rhinitis.
What a relief.
Now let's discuss common findings of the ear in allergic rhinitis. Otoscopy should be performed to look for tympanic membrane retraction, air fluid levels, or bubbles in the ear. Pneumatic otoscopy can be considered to check for abnormal tympanic membrane mobility. These findings can be consistent with allergic rhinitis, especially in cases where eustachian tube dysfunction or secondary otitis media is present. Now let's discuss the nose examination. If I were to look inside the nose of a person with allergic rhinitis with the nasal speculum during examination, I would typically observe clear nasal secretions with an edematous, blanched mucosa. The mucosa of the turbinates is usually pale or violaceous due to venous engorgement. They appear blue or gray in color, and this is a classic finding of allergic rhinitis. I may also see one or more yellowish, boggy masses called nasal polyps growing in the nasal cavity, especially if the person has a long history of allergies.
I definitely have a lot of clear mucus in my nose. It tends to be watery and I have to blow my nose multiple times a day.
That reminds me. It is important to assess the character and quantity of nasal mucus. Thin, watery secretions are associated with allergic rhinitis, while thick, purulent secretions are more typical of sinusitis. Though thicker, purulent, colored mucus can also occur with allergic rhinitis. The nasal septum should be examined to look for any deviation or septal perforation, which may be present due to chronic rhinitis, cocaine abuse, prior surgery, topical decongestant abuse, or, rarely, topical steroid overuse. Common to the clinical presentation of allergic rhinitis is something called the allergic salute, where a person wipes the nose upwards with the palm of the hand. This is most common in children and can cause a transverse nasal crease to appear on the nose.
Cobblestoning is a term used to describe streaks of lymphoid tissue on the posterior pharynx, which is commonly observed with allergic rhinitis. This can be observed during examination of the throat. Tonsillar hypertrophy may also be present. Malocclusion, overbite, and a high arched palate can be observed in patients who breathe from their mouths excessively and should be noted if seen on the throat examination.
The neck should be examined for lymphadenopathy and thyroid enlargement. It is also important to listen to the patient's breathing and note any abnormal breath sounds, especially wheezing. Asthma commonly occurs alongside of allergic rhinitis.
Allergic rhinitis can also cause significant impairment of sleep, which can lead to fatigue and difficulty concentrating during the day. Gathering enough information from the patient to obtain a complete history is an important piece of the allergy workup.
Obtaining a detailed history is indeed an important step in the evaluation of allergic rhinitis. Important components of the history include an evaluation of the nature, duration, and time course of symptoms, possible triggers for symptoms, response to medications, comorbid conditions, family history of allergic diseases, environmental exposures, occupational exposures, and effects on quality of life. A thorough history can help identify specific triggers, suggesting an allergic etiology for the rhinitis. Past medical history should also be investigated, including other current medical conditions. Diseases such as hypothyroidism or sarcoidosis can cause non-allergic rhinitis. Concomitant medical conditions need to be considered as they may influence the choice of medication. Quality of life should be considered. Determine the presence of symptoms such as fatigue, malaise, drowsiness, and headache. Investigate sleep quality and ability to function at work. Because allergic rhinitis has a significant genetic component, family history makes the diagnosis more likely. However, the cause of allergic rhinitis appears to be multifactorial, and a person with no family history of allergic rhinitis can develop allergic rhinitis. Determine the age of onset of symptoms and whether symptoms have been present continuously since onset. While the onset of allergic rhinitis can occur throughout adulthood, most patients develop symptoms by the age of 20. Environmental factors should also be evaluated. A thorough history of environmental exposures helps to identify specific allergic triggers. Ask the patient about humidity levels in the home, dust levels, time spent outdoors, work and school environment, and the relation to timing of symptoms. This might provide important details about triggers for seasonal rhinitis.
During periods of exacerbation, determine if symptoms occur on a daily basis or only on an episodic basis. Determine whether the symptoms are present all day or only at specific times of the day. This information can help suggest the diagnosis and determine possible triggers.
Response to treatment with antihistamines does support the diagnosis of allergic rhinitis, but sneezing, itching, and rhinorrhea associated with non-allergic rhinitis can also improve with antihistamines. Response to intranasal corticosteroids supports the diagnosis of allergic rhinitis, although some cases of non-allergic rhinitis also improve with nasal steroid use. Immunotherapy may help. A positive skin prick test can confirm allergic rhinitis. In summary, the typical clinical presentation of allergic rhinitis involves observance of inflamed nasal membranes along with any combination of sneezing, congestion, nasal itching, and rhinorrhea. The allergic response may be associated with allergic conjunctivitis, palatal or pharyngeal itching. Other physical examination findings of the ears, eyes, nose, skin, and throat may be consistent with allergic rhinitis. There is a strong association between allergic rhinitis and asthma, as well as chronic sinusitis and atopic dermatitis, and this should be considered in the treatment of allergic rhinitis patients. This concludes our presentation. Thank you for joining us.